Good day, dear colleagues. We're glad to see you in our webinar, Crystal Vision Eye Clinic webinar by Professor Igor Aznauryan. And today will be the continuation of the webinar that was on previous Wednesday. And today, Professor Igor Aznauryan, head of Crystal Vision Eye Clinic, will talk about nystagmus surgery, approaches, innovations, how we do surgery in patients with nystagmus, not only kids, but also adults. If you will have questions, please write them in the chat or questions, and we will for sure answer on them after the webinar. Thank you so much.
Hello, dear friends. I am glad to see you all at our wonderful webinar today. Thank you much for taking the time to attend this webinar. Moreover, it seems to me that the topic is worthy of it. It is very interesting and is called nystagmus surgery, innovations and technologies. Moreover, the topic is worthy of your attention. Surgery is not stagnant. Technologies and innovations. Last time, we told you Victoria Olegovna Balasanyan shared an interesting story about nystagmus, about the features of modern diagnostics that show eye movement and reveal many other important aspects of this condition, such as various other factors. The most important thing is how to determine the purity, amplitude, and point. I am just reminding you. What you had last time, how to determine the null point or the blocking point of nystagmus. All these modern aspects of understanding the characteristics, individual characteristics of nystagmus in a particular person, you were given information in the previous lecture, and today we will talk directly about such very important things as treatment. So after you have diagnosed all of this, how do we actually treat it? The necessity of surgical intervention for nystagmus should be perceived as 99% of cases in surgery are a radical and effective way to reduce the amplitude and frequency of nystagmus. And why is it necessary to do this? Here on the slide are the main causes that can be improved, significantly improved in these patients, and enhance their quality of life. These improvements can greatly benefit their overall well-being. Well, as we mentioned again in the last lecture, stagmography allows us to determine the most important characteristics of nystagmus. This is the frequency and amplitude of various gaze positions, determining the null point. As you can see here, right, the eyes deviate upwards and to the right, and they get blocked there. This is what we need for surgery. In this slide, we decided to show you which surgical treatment options are the most common or used by various surgeons today. Here, I must say that the choice of a particular surgical tactic depends more on the surgeon's qualifications than on the clinical necessity to perform a specific operation. It is important to understand this. Historically speaking, if we take a look back, it must be said that in 1953, Anderson and Kestenbaum, independently of each other, suggested that the incorrect head position associated with nystagmus could be alleviated surgically. The following year, Goto made similar proposals. For this, it is necessary to identify the null point and transfer these null points to the primary position of gaze. Anderson's proposal was for the recession of two rectus muscles on the opposite side of the head turn. For example, when turning the head to the right shoulder, it was necessary for Anderson to perform a resection. So I picked up the nozzle and the outer straight on the gas to the left. Years have suggested taking their agonist muscles and thus here, resection of two rectus muscles on the side of the head turn. Kestenbaum approved the surgery on all four muscles, that is, resection of the two rectus muscles on the side of the turn and recession of the two antagonist rectus muscles, although he adhered to a sequential approach. Gradually, at once. Currently, modifications of surgeries related to shifting the blockage point to one side or the other do not mention either Goth or Agassiz, indicating that our perspective is not very accurate. And probably in the future, we will return to this conversation at larger conferences, for example, in the United States or somewhere else in Europe, and say that in general, such a state of affairs is not very correct. From an academic point of view, these are the main surgical strategies. Well, it is very important to understand whether a patient has an exophoria or esophoria deviation. As you know, it is quite difficult to determine this in a patient with nystagmus. And indeed, yes, it will be necessary to cut the fusion reserves to understand how much to transplant these muscles. However, it must be said that the use of Kieslab, a technology we have already mentioned to you, facilitates the task of determining the individual characteristics of a particular patient in terms of the presence or absence of latent consent. All 4 rectus muscles are resisted by their cotton. In our modification, in our proposal, we provide for the weakening of the muscles. The choice of muscle depends on the location of the blockage point. As a rule, the blockage point, when we look at the legs from below, is usually displaced. It can be displaced either sideways, upwards, or both sideways and upwards. It is located diagonally, at a certain number of degrees to the side, and at a certain number of degrees upwards or downwards. And we also perform recessions of the rectus muscles, upper or lower. Where is the vertical component of this very point of blockage located? And if we talk about the history of the issue, the technique of horizontal recession was first performed in 1960. Beatty and Bagolini recessed all 4 horizontal muscles beyond the equator. In our modification, we also recess beyond the equator, but we precisely calculate by how many millimeters to do this, which we will explain below. To move the null point to the primary position, it is necessary to apply efforts on the side of the slow phase or weak efforts on the side of the fast phase. This is, some terminologies that they use like Galini. In this case, we are talking about jerk nystagmus. However, it can be understood that the null point can also occur in patients with pendular nystagmus. And there, as we know, there is neither a fast nor a slow phase, nor a strong nor a weak side. And therefore, we might get a little bit confused. Therefore, it is important to properly adjust the muscles in such a way as to correct and move the blockage point to the central position. The technique by which these displacements and muscle weakenings are achieved includes both the fans during the operation and possibly tenotomy, which may have been proposed. There are many different options in general. I won't list them all right now. I would like to move on to our methods for today as soon as possible because, in our opinion, they are the most effective, the most productive, and most importantly, the most calculable. We can calculate very precisely how to make all these movements, these recessions, especially when it comes to deep recessions. Precision is very important because, as we know, 0.5 millimeter, 1 millimeter more or less, and we get completely unmanageable results. Thus, we have developed and effectively used for about 20 years a modification that we call deep recessions, the technology of weakening through deep recessions. Deep recessions terminologically. What does deep recession mean? This is a recession of the muscle beyond the vertical equator line. Once again, beyond the vertical equator line. Let's return once more to video nystagmography, to note that it is an objective study that allows for determining the viewing direction with degree-level accuracy. It is important the method is usable for young children, those with low vision. This program calculates the lock point, provides us with the corresponding protocol, and we know exactly where this point is located. This can be repeated, and the frequency and amplitude can be observed in various viewing positions, thus determining the presence of precise lock points. And here, when planning the surgery, we use our system for calculating the dosage of the operation. We model the surgery accordingly, determining how much recession is needed and how far to transplant beyond the equator to achieve the patient's original individual parameters. This refers to the length of the anterior and posterior axis, the length of the transverse axis, and the diameter of the cornea. And here we get the point where the equator is located. Then the program calculates how much recession we need to perform beyond the equator for certain muscles. Separately, we probably need to talk about those cases when they are combined with strabismus. There, we have the opportunity to do a bit more on one side and a bit less on the other, the same recession, in order to simultaneously correct the strabismus as well. Additionally, surgeries can be performed sequentially, first correcting the strabismus and then proceeding to other surgeries. No nystagmus, or certainly indeed definitely the opposite. The fact is that the strabismus angle really affects the position. On the right, fold. And now, let's lift the eye. Let's do it again, before the surgery. Before the surgery, and here is after the surgery. As you can see, almost completely blocked movement, and most importantly, we corrected the strabismus angle significantly. The fact is that the strabismus angle has a strong influence on the lock point. So we always try to correct the strabismus first to more accurately determine the location of the lock point, and then plan the surgery accordingly. However, we recommend avoiding higher surgeries because we do not achieve the desired effect from strengthening agonists. Our extensive experience shows that recession and weakening surgery are significantly more effective. The calculation of the intervention based on the presented parameters is very individual for each patient, and we accordingly measure all the necessary values and then enter them into the program. Accordingly, we measure all the necessary measurements and then enter them into the program. The program calculates and shows us by how many millimeters this or that recession goes beyond the equator. As I have already told you about this, here the patient's parameters are entered, and now you have the chance to observe how this is actually done in practice. I want to say that all the parameters mentioned above here as well, yes, they are in a trigonometric dependency. That is, they depend on each other through a special formula, equations. This equation is not empirical, it is purely mathematical. This is how the behavior of electrons in quantum mechanics is determined. Data is subtracted based on mathematical calculations, and the equation is exactly the same. Here, based on biomechanical equations, we derived a formula for biomechanics. We have the ability to combine all these individual parameters, which allows for very high precision in surgery. Thus, correcting strabismus angle, bringing 0 point to central area. So, basically, the dosing of operation, C, using this program we called Straba, and it has very high accuracy. This is the maximum precision available today in neurosurgery. Now we will show you. We are working with a radio wave knife, as you can see. We do not use scissors. We do not use any cutting tools here at all. Besides the knife and the radio wave knife, this allows us to perform the operation very gently. And this allows us to minimally injure the tissues. Healing occurs very quickly, and the geometry is very short. We use 7-0 threads, as you can see. These threads also minimally injure tissues, and the needles do too. They are thin and do not cause much trauma. So, we measure the distance to the equator. It is also calculated for us, and further, by that very formula. And then we measure the distance from the equator to the place of recession. We stitch this area with threads to ensure meridional symmetry. If the muscle did not go up, down, or to the side, and then, here we go, we stitch it. And we cut. Accordingly, we tie. This is the technique we use. Excellent. This is a very high level, high technique operation. You can see that the muscle is stitched to the equator at 2 millimeters, and we will do the same with the other muscle. You see the technique of tying knots during lips and recessions. This allows us to avoid complexity, avoid complications related to the deep heart. The stitches need to be placed deep beyond the horizontal plane carefully. You can clearly see the effectiveness before and after the operation. The eyes are almost completely blocked. These are the results of the procedure. See before and after. Almost blocked eyes. Compare the face before and after the operation. Here, with you, what seems useful? Right here now. The same thing, you see. We hold the patient, they keep trying to move their head away, and here it is already after the operation. Indeed, practically blocked areas. The central position, specifically the head, is held straight. Thus, there are no winners. We do not have a reading of nystagmus ametropia. Here I must mention the possibilities we have. In performing laser correction in patients with nystagmus, we have developed a very good method for performing laser operations under anesthesia. Therefore, we can perform them on children. We start from the age of 6 to 7 years and older. And we eliminate all the difficulties that such children face. And for adults too, not just children, related to Instagram. This is our no glass, contact lenses, and other priorities. As a rule, they all have it, ametropia as we know, and we can remove this ametropia. A person already with a direct, almost blocked or almost blocked places, and without glasses, normal quality of life returns. This means directly the same percentage before the operation. As you can see, this is not nystagmography. I do not mean frequency and amplitude, and indeed, after the operation, well, this is not stagmography. You see the numbers. They convey information. Well, that's all, friends. I am very glad that we were able to talk today. Indeed. Thank you very much for your attention. My colleagues and I are always at your service. We will always be happy to answer your questions. And most importantly, we will be very pleased if we start collaborating with you. To collaborate in order to benefit all of our patients, both young and adult. As for the specific technique, you can simply bring your patients and watch these operations. We will be glad if this whole story interests you. Believe me, it is worth it. Thank you very much once again, and see you next time.
Thank you, Professor Igor, for this talk. I think for all of us, it was very informative. We will be able to use it in our practice with patients who have nystagmus. So next Wednesday, we are gathering at 8 a.m. And we will talk about latest advances in refractive surgery. We will talk about different techniques and how they appear, and what now is the best way for using of refractive surgeries. Thank you for being with us today in the morning. It was a great honor for having you today in the webinar. If there will be any questions, please ask them before or during our meetings. Thank you so much. Have a good day.